By the end of this video, you should be able to answer the following questions. What is asthma? What is the common presentation? What are the best initial diagnostic tests? What are the most accurate tests? Why do we use methacholine and when? What are the steps of asthma management? What are the causes of asthma exacerbation? How to identify the severity and how to treat it. So grab your coffee and let's go. Asthma, simply put, is an abnormal bronchoconstriction of the airways. It is reversible, unlike the COPD. Presentation will be cough, wheezing, chest tightness, or difficulty breathing 3 to 6 times per week. Symptoms are usually worse at night. It might be associated with nasal polyps and sensitivity to aspirin. Also, eczema and atopic dermatitis might be found in the patients. Increased length of expiratory phase of respiration and increased use of accessory respiratory muscles. The best initial test in an acute exacerbation of asthma is peak expiratory flow or arterial blood gas. Chest X-ray is used to exclude pneumonia and other diseases such as pneumothorax and congestive heart failure. The most accurate diagnostic test is pulmonary function testing. The spirometry will show a decreased ratio of forced expiratory volume in 1 second over forced vital capacity. The decrease in forced expiratory volume in 1 second is more than the vital capacity, and you will find increased diffusion capacity of the lung for carbon monoxide, which is opposite to the finding that you will see in COPD. In case that the pulmonary function test is normal without bronchial hyperreactivity, we might need to do a provocation challenge, or we might use methacholine, exercise, or histamine. To diagnose asthma, we need to find a decrease in forced expiratory volume in 1 second by 20% using methacholine, or an increase by 12% using albuterol. Methacholine is an artificial form of acetylcholine. Now, when do we use the methacholine challenge? We use it with asymptomatic patients, because with asymptomatic patients, it is less likely to find an increase in the forced expiratory volume in 1 second using short-acting bronchodilators. We use the methacholine challenge to evaluate cough variant asthma or exercise-induced bronchoconstriction. In the presence of normal pulmonary function test, there's 1 to 2% risk of inducing status asthmaticus, which is severe asthma not responsive to treatment, and it is a medical emergency. Now, the management of asthma consists of steps. The first step is using short-acting bronchodilators or short-acting beta agonists, like the albuterol. If the asthma is not controlled by short-acting bronchodilators, you should go to the second step, but first you have to make sure that the patient is taking the right dose and taking the medication in the right way, so you don't face the following situation.
You're using your inhaler?
All the time. Go through 1 a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Once you made sure that the patient is taking the medication correctly and asthma is not controlled, then you should move on to the second step, which is adding a long-term control agent. The best initial long-term control agent is low-dose inhaled corticosteroids. There are some alternatives in case you cannot use the inhaled corticosteroids, like the mast cell mediator release inhibitors and the eosinophil recruitment inhibitors like the chromonil. Theophylline also can be used, and leukotriene modifiers like the montelukast and zafirlukast can also be used as alternatives to low-dose inhaled corticosteroids. The third step is adding a long-acting beta agonist to the short-acting and the inhaled corticosteroids, or increasing the dose of the inhaled corticosteroid. An example of the long-acting is salmeterol. If asthma is still not controlled, you can move on to the fourth step, which is increasing the dose of the inhaled corticosteroid to the maximum, in addition to the long-acting and the short-acting. An alternative or an additional drug can be used here, which is tiotropium, an antimuscarinic agent, in case the step 4 is not sufficient. Step 5 is using omalizumab, which is an anti-immunoglobulin E. We can add this medication in cases with increased immunoglobulin E levels. Step 6, using oral corticosteroids such as prednisone. There are some alternatives to the corticosteroids, like the monoclonal antibodies and anti-interleukin 5, like the rislizumab. Also, bronchial thermoplasty can be used in cases of chronic asthma. There are some points that we need to point out about the management. Using the short-acting bronchodilators for 3 days or more per week indicates poor control of symptoms, and this means that the treatment should be intensified. In asthma management, levalbuterol should be considered in patients with atrial fibrillation, but this is a controversial point. Zafirlocast, which is a leukotriene modifier, is hepatotoxic, and it is associated with Churg-Strauss syndrome. So you must be careful when using these agents. Influenza and pneumococcal vaccines are given in all asthma patients. Long-acting beta agonists have numerous side effects and are associated with increased asthma-related deaths, and they are always used in conjunction with inhaled corticosteroids. So never use long-acting beta agonist alone without inhaled corticosteroids. If the patient has increased immunoglobulin E levels, then we might need to use the anti-immunoglobulin E medication like omalizumab. These patients are associated with allergic bronchopulmonary aspergillosis. A common triad that you should know about the asthmatic patients is the Saunders triad, which is having sensitivity to aspirin, having asthma, and having nasal polyps. So be careful when using non-steroidal anti-inflammatory drugs and aspirin with asthmatic patients. You should try to avoid using corticosteroids in the management of chronic asthma because they have several side effects. Try to remember the side effects by memorizing the mnemonic Cushingoid. Side effects are, or the common side effects are, cataracts, candidiasis, ulcers, striae, skin thinning, hypertension, hirsutism, immunosuppression, infections, necrosis of femoral heads, glucose elevation, osteoporosis, obesity, impaired wound healing, depression, and mood changes. Now let's talk about acute asthma exacerbation. The severity of an asthma exacerbation is quantified by decreased peak expiratory flow or arterial blood gas, in which we will find increased AA gradient. The simplest way to explain this gradient is that it's a measure of the difference between the alveolar concentration of oxygen and the arterial concentration of oxygen. Now, what are the causes of acute exacerbations of asthma? They include allergens such as pollens, dust mites, cockroaches, and cat dander, infection and cold air, emotional stress, exercise, catamenial, which is related to menstrual cycle, using aspirin, non-steroidal anti-inflammatory drugs, beta blockers, histamine, and any nebulized medication, tobacco smoke, and gastroesophageal reflux disease. How do we treat the acute exacerbation? The best initial therapy is giving oxygen, albuterol, and a bolus of steroids. If there is no response or respiratory acidosis develops, we should intubate the patient. Ipratropium should be used, but it doesn't work as rapidly as albuterol. Magnesium is used only in an acute severe asthma exacerbation, which is not responsive to several rounds of albuterol while waiting for steroids to take effect. The corticosteroids might need 4 to 6 hours to begin to work, so you should give them right away. If you like the video, please hit the like button and subscribe to our channel to see more of this content. And while you're at it, share it with your friends.